And so we got to get on up there on the scanning ability. You know, I'm going to be here all day Friday. I'll be here till 5:30 tonight. So come to me, okay? A lot of people have asked, can I help with the written Friday? I can, but scanning will come first. So as long as I'm not doing anything with someone else scanning wise, I don't care to help y'all with the written part of it. This Friday was kind of dedicated to scanning because y'all are not the only ones that the seniors are. They're way below level, and they know they are. So it's a day for everyone to come.
What time again?
It's going to start at 9, and it'll go to 2:30, and I will be going from 2:30 to 6:30. Got to my kids to their dad. Then I'll be back from 6:30 to 10. So it should work out all right. 10 o'clock. Yeah.
Hey, were you talking about if we failed the exam?
If you failed that exam, then you need to, I don't know if they're not, but you need to be up here scanning with me, okay? Because y'all will start clinical this quarter, and I do have the option not to send you out if I don't think you're ready. And I don't want to keep anyone from going because I don't feel like you're ready, because you are going to be scanning out there. So we have to watch out. We are coming from a bad reputation from when the program first started. Vascular was not that great. Thankfully, not just because of me, but because of help that I've also had, the program is getting a lot better, and our name is getting better. So I don't want to send anyone out there and bring the name back down. Okay? But anyhow, so some helpful hints when you're doing a carotid scan to tell. Some of you are still having trouble, especially when you get to the ICA. Get confused between the jugular vein and the ICA. Okay? So what I want y'all to start watching for is this up here. Oh, not that one. There is a very simple thing that you can look for. Right, I'm going to go right here to the CCA first. When you first put your color on, your color scale should be red on top and blue on bottom. Okay? CCA color scale should be red on top, blue on bottom. Right? Now, when you go up to do the I and the E, you turn everything the opposite way. So what happens is when you start an exam, you calibrate the machine the way you want it, okay? So the very first color image we did was calibrating the machine going towards the left of the screen or the right of the body, and our color scale was this way. But what happens is when we go up here to do the I and the E, all right, now everything's going the opposite way. So that means our color scale has to be inverted, okay? When you get up there to do your I and your E, if your color scale is not inverted to blue on top, then you're going to be making your arteries blue and your vein red. And so that's why some of you are calling your jugular vein your ICA, because it's coming in red. Okay? So just watch that right there. Very simple. You got that correct. You're going to make your arteries are coming red and your veins are coming blue. Okay? When you get to the I and the E, color scale should be blue on top. Now, another common mistake is the vertebral. All right, so here we went from ICA going this way. Now we got the ECA, so we kind of turn our machine, calibrate it a different way. So then when we get back to vertebrals, they angle the same way as your CCA, which I need to talk about today because I keep forgetting. All right, so when you get back to the vertebrals, what do you got to do to your color scale? You got to invert it back to red on top. All right, that way your vertebral artery will come in red and your vein will come in blue. Again, if you don't invert your scale back, you're going to make your vein blue and you're going to Doppler making it an artery. All right? So if you'll watch those three things right there, it's going to help you know the difference between artery and vein. All right? That's pretty much my helpful hints for now. All right. Yeah. I've seen that the seniors were also doing that. They weren't flipping their scale, and they were getting confused too. And then I really help them start paying attention to that color scale. So I think it will help y'all.
Well, your scale is just through the box.
Nope. There's a, you know how you can, let's say your waveform shows up on the bottom of the baseline, you can invert. You have the same thing with color. Then invert it and make the color scale invert. That's all you have to do. Good question. All right, now there's a reason that your CCA has to angle the same, or your vertebral has to angle the same way as your CCA. Now, it's not a law that it has to, okay? It just makes your job easier if you go ahead and do it. So when you look in your textbooks, when you get out on the job, you're going to see that not everybody angles their vertebral the same way as their CCA. But it's just a way to make your job easier for you. Because what is it if the vertebral is truly retrograde that we're looking for? Subclavian steel, okay? But what you'll see a lot of techs do is they'll find retrograde and they'll just invert it and make it antegrade because they don't want to deal with it and they don't think it's truly retrograde. So there's a way to check the cell to know if it really is retrograde or not. So let's say I find this picture right here. And when I first started Doppling it, it was retrograde. So I hit invert and made it antegrade, okay? To make it look normal. Before I can move on and say that that was truly, that just needed to be inverted, okay? You have to hit update, okay? And don't change your color box, don't change your angle, don't do anything to that. Hit update and just slide over into the CCA and Doppler that. If that is also antegrade, you're good, okay? But if you go to Doppler the CCA with that exact same angle and it's retrograde, then that meant that that vertebral was truly retrograde and you should have never inverted it, okay? But if you don't angle it the same way as your CCA, because we all know CCA has to go one way, has to, there's no option for that, but vertebrals don't. So let's say I angle my vertebral the other way, well, that's already calibrating the machine a different way than my CCA goes. So that little trick is not going to help you out. If you'll go ahead and angle it the same way as your CCA, hit invert, make it antegrade, done. Okay, so I'm saying, okay, it's not really retrograde, I just need to invert it, but I need to check myself, so I'm going to hit update, keep everything I've got here, go to the CCA, put my Doppler in there, and it don't matter if it's parallel, okay? You just put it in there, and if it's also antegrade, then I'm good to go. Again, if I Doppler the CCA and it's retrograde, then that meant that that was truly retrograde in my vertebral. So now I need to start checking for subclavian steel. So I need Doppler subclavian, and we know on and on. The subclavian's retrograde, then we got to the CCA because of the denominant. So that's when you're going to start that process of checking yourself. Okay? So again, in here, I always want the vertebral going the same way as your CCA. Friday or today, whatever. If you don't understand what I'm talking about, I can show you how to check yourself. It's real simple. Alright? Just keep that in mind. That's it on carotid for today. We're going to jump back into doing the venous study. I normally don't do subclavians until vascular 3, but I can. 90% of the sites don't do them, but you may end up with a site that does. So if any of y'all end up at a site that includes the subclavian in your carotid study, just let me know. I'll show you how to do it. Or if you want to go ahead and know, let me know and I'll show you how to do it.
Did somebody not get a chapter 6 on that?
Alright, so chapter 6 just continues on with venous studies of the leg, and we know that the number one reason in the leg is what? A blood clot, okay? And another word for a blood clot is a DVT. DVT stands for deep venous thrombosis, and I'm just reading off here, okay? On chapter 6. It says DVT happens 1 in 10 million cases. So not a whole lot common about them. But one of the most dangerous things about getting a blood clot in your leg is that it will break loose and become an embolus, okay? Once it becomes there, we worry about getting into the lungs. Now, just because you have a blood clot in your lung does not mean that it is dangerous. It has to get into the main pulmonary artery to become life-threatening. So, if you know someone that has a blood clot in their lungs, I think they're going to die in 30 minutes, all right? If it gets into the main pulmonary artery, that's when they have statistically 30 minutes to get to the hospital before they will die. Right? So pulmonary embolisms are dangerous, but they have to be in that main pulmonary artery. And again, statistically, they have 30 minutes to get to the hospital to get it broke up. Okay? So that's what you worry about, and that's why it's so important to put color on the vein before you compress it. Everybody get to see me compress the vein the other day? Okay, good. Now, it says underneath that this amount of number of deaths come from PE. Again, I don't expect you to know those numbers. I'm just saying that, again, once it gets in the main pulmonary artery, that's when we will begin to worry about it. The word VQ scan, go ahead and just know what that is. If we find a blood clot in their legs, they're going to go to CT to have a VQ scan of their lungs to see if they have one in their lungs, and if so, where is it at? Is it in that main pulmonary artery, or is it away from it, okay? So a VQ scan is just a CT of their lungs to see if they have a blood clot.
Yeah.
You have to just write it in. Yeah. VQ scan, and it's used, it's CT, and it's just used to see if you have a blood clot in your lungs. And it's CT does it, and it's used to see if you have a blood clot in your lungs. All right, again, if a patient has a VQ scan and they find blood clots in their lungs, guess what? They're getting an ultrasound of their legs to see if they have any more that could break loose and go to their lungs. So they just work one and one. So you're going to hear VQ scan a lot once you start working. It says the most common cause of, this is the third most common cause of death in hospitalized patients. Why? What happens when you just lay around a lot and don't move? The blood just sits there, so it has a chance to stick together and form a clot. So that's where the compression hoses come into play. They act as a Casvino motor pump. You see the ones that blow up, the white things that they are. They're pushing blood up out of the calf to keep the circulation going. So that's what they have to have those for. So there's three things that have to be going on in your body to even develop a blood clot. And it's called the Thirst-Couch triad. See that word? Alright, Thirst-Couch triad. Three things that have to be going on for a blood clot to form. Now, it doesn't have to be all three things. It just has to be one of the three things. Okay? Or it could be all three. It just depends. One of them is called circulatory stasis. And that means slow versus fast. Is your blood moving slow? Is it moving fast? That's what circulatory stasis means. Fast versus slow. Obviously, blood that's moving slower will stick together quicker. Okay? They can check that. The second one is a vein wall injury. All right, veins are supposed to collapse as they squeeze blood up. Right? If the vein walls cannot collapse and squeeze the blood up out of them, what's going to happen? That blood's just going to sit there, right? So that's a vein wall injury. Blood is just sitting there, does what? Increases the risk of a blood clot, so they can just stick together. So vein wall injury prevents flow from being squeezed up and moved to the next level, so it just sits there. Alright, get that? Prevents flow from moving because veins cannot compress and squeeze the blood up. And then the third one is hypercoagulability state, that's hematocrit. You have a high hematocrit level or a low hematocrit level. Okay? So hypercoagulability state is talking about your hematocrit. Is your hematocrit level high or is it low? And a higher hematocrit is thicker blood, again, so it will stick together quicker. So if you have one of those three things, two of them, or all of them, that increases your risk of developing a blood clot. Okay. Now, some other risk factors that you could be going through. All right, the other Thirst-Couch triad is your body, inside your body's going on. These are risk factors that you have outside of your body that may be going on. Have you had surgery? That's what post-op state means. Anytime you've had surgery, increases your risk of a blood clot. Why? You're just lying around after surgery. All right. A previous DVT increases your risk of having another one, just like a previous stroke increases your risk of having another one. Okay. Cancer increases your risk for a blood clot. Trauma, pregnancy, high-dose estrogen, that's birth control. We all know birth control increases your risk. Immobility, so if you're sitting or even standing for a long period of time, let's just sitting there. Thrombophilia, that is you're prone to getting clots. That's a condition that you have. So thrombophilia is something going on inside of your body that causes you to be prone to getting clots. And then the bed rest goes along with immobility. So bed rest more than 4 days will increase your risk again. Okay? So those are just some of the risks that you could be going through to increase your risk of a blood clot. Now there are different types of blood clots, like there are different types of strokes. You have an acute, so go ahead and just write this to the side. we will talk about it, but just want to be sure I have it written down. You have what's called an acute DVT. Acute DVTs have been there for less than 4 weeks. Acute DVTs have been present for less than 4 weeks, and they are the most dangerous types. Okay? And we will discuss why. So, with an acute DVT, the reason it's the most dangerous is the longer a blood clot has been inside the vein, the more time it has to attach to a wall. Once it attaches, it can't throw. Okay? So an acute DVT is just floating around in a vein. So those are the types that if you compress them, you're going to throw them. All right? So acute DVTs are free floating. That's what you need to know about them. They're free floating. They're just floating around in a vein. Now, on ultrasound, they're anechoic, so you can't see them. All right? So that's another reason they're so dangerous. They're anechoic, and you can't see them on grayscale. So how you gonna know if they have a blood clot if you can't see it on grayscale? What are you gonna do? Put color on it, and the color doesn't fill in. There you go. That's why you have to put color on things first, okay, before you compress them. Because if they have an acute DVT, it's anechoic, it's gonna look normal, and it's free floating. So you're not always gonna throw it, but there's a high risk that it's good.
That did not scare me.
I warned her.
So it's not like a bomb.
All right, acute DVT, the vein is normal at size. So that's another thing about it, okay? So with an acute DVT, the vein is normal in size. So if you pull up a grayscale image of an acute DVT, the vein's going to look normal, and it's going to be anechoic. So you're not going to know it, it's just put that color on. So acute DVT is less than 4 weeks. It's the most dangerous. Why? Because it's free floating, it's anechoic, and the vein is normal size. So on a grayscale image, everything looks beautiful. All right? Now the next category is called subacute. And I promise you, if you go to a doctor and tell them it's subacute, they are going to trust you with their life. There's so many techs who don't know what subacute is. All right? So subacute has been present for 4 to 12 weeks. It is, but I just want to go ahead and tell you now in case I forget to tell you something about it.
Did you say less than or more than
It's
12?
4 to 12 weeks.
4 to 12.
Mhm. Subacute is 4 to 12 weeks. Now with subacute, the vein is still normal size. The only difference in acute and subacute is subacute, the thrombus has been there longer, so it's starting to age, so it starts to get brighter. So now you can see the thrombus inside of the vein, okay? So subacute is 4 to 12 weeks. Your vein is still the normal size, but now you can actually see those echoes of thrombus inside the vein. It is still, but the good thing about it is you can see it, so you know not to compress it. So that's why it's not the most dangerous. It is still dangerous because it is still floating around in there, but you can see it, so you know, hey, I don't need to compress that because veins are supposed to be anechoic. All right? So subacute is 4 to 12 weeks. Your vein is a normal size, but now with grayscale, you see the thrombus in there. All right? The longer the thrombus is, the brighter it gets. All right? So less than 4 weeks, we're still anechoic. 4 to 12 weeks, I'd say closer to 12 weeks, it starts getting brighter. So we know it's there and we know not to compress it. But again, it is still dangerous because it is still floating around in there. And then the last one is chronic DVT, and it has been present for more than 12 weeks. So chronic DVT, longer than 12 weeks. Chronic DVT has been present for more than 12 weeks. It is the least dangerous. Why do you think it's the least dangerous? Because who? It's attached to the wall. Very good, y'all listened. Alright, because I said the longer it's been in there, the longer it's going to have to attach to the wall. So chronic DVTs are attached to the wall. So guess what? You can press them all day long, they're not going to go anywhere. So ultrasound-wise, the vein has become contracted, smaller. So normally the vein is bigger than the artery, okay? If the vein is the same size or smaller than the artery, that is seen with a chronic DVT, okay? So I would just say smaller than the artery, because that's what you're commonly going to find with a chronic DVT. Now your vein is smaller than your artery. Obviously, you can see the thrombus in that all day long because it's going to be almost white. The longer it's in there, the brighter it gets, okay? So now it's almost white. You know on grayscale, obviously, you can't compress it if you want to, but no guessing they have DVT. So again, it's your least dangerous. The vein becomes smaller than the artery, and the thrombus is bright white. Now, some things that chronic DVT will do that's a little different than any of the other ones. I know I can't draw, so just bear with me. Alright, chronic DVT usually is going to include the entire vein, right? So write that down. Chronic DVT eventually will cause the entire vein to become occluded. Chronic DVT, over time, keeps building up and the vein becomes occluded. If this happens, there's two ways that blood can get around the DVT. Okay? Because blood has to pass. Let's say it's in my mid-SFV. If I have a chronic DVT in my mid-SFV, how's it going to get to my process SFV? There's got to be some way. Alright, the first thing is it forms collaterals. Collaterals are just like little projections that go around. It's just like little, they call little finger projections. So it starts to form what's called collaterals, and these collaterals will hook up to the next vein. Okay? So collaterals, or they call them finger-like projections. It's your body's own way of making a bypass graft. That's what a collateral is. Okay? Well, in ultrasound, they have little fingers sticking out from the vein. So they will provide blood flow around this so that it gets to the next level. Alright, so that's one way. Alright, another thing that your body can do is it can form what's called recanalization. And that is one word I can't spell. Alright, so spell it. Oh, I'm running out of room. So I can read that part. Recanalization, just like it sounds. That's another. So your body will form collaterals. That's your own body, your body's defense of a bypass graft. Just like it sounds, it takes blood around the obstruction and gets to the next level, just like a bypass on a highway. Another thing your body can do is do recanalization, and it's like a little worm. It digs a tunnel through it to get blood through it. So recanalization is a tunnel, like a little ringworm or whatever. It digs a tunnel through it and gets blood through it. Okay? So that's options that your body has. So if you have a recanalization, that means blood's going all the way through here. It doesn't have to be in the middle. That's just the way I drew it to get it to the next level. So chronic DVT is either going to form collaterals or it's going to recanalize, and that's just a tunnel that goes through the vein to get blood to the next level. Okay? So since we're on this, what did we talk about is another option for reflux if it's not your bowel. It's what? Chronic DVT. And we talked about that, chronic outflow obstruction. If your body doesn't form any of this, the blood flow simply cannot pass. So what does it do? It just goes back down. Okay? So we need those to form in a chronic DVT. So we got acute, subacute, and chronic. Different characteristics on ultrasound, how long they are, what they do. Alright.
So will they ever put a stent in the legs?
You can actually go in and they can put a bypass graft. They can use the greater saphenous vein. It's the most common one because you don't have to have it. And they can connect it in, so let's say this is the mid, let's say they can connect it into the distal and the prox and get blood around it, if that happens. They can do that, or they can actually go in and clean the thrombus out, whichever option they prefer to do. So there are ways to get rid of that if those don't form. Alright, now symptoms of acute DVT. So acute lasts longer than 4 weeks. So you're gonna have a sudden onset of persistent calf pain or tenderness, okay? Persistent calf or leg swelling. And it says symptoms that have lasted longer than 2 to 3 weeks are usually not because of a DVT. So it's probably going to be because of a muscle tear or something. This means it comes on suddenly and you can't handle it. It ain't something that started 2 weeks ago and it's progressively getting worse. This will happen suddenly. Now, anterior leg symptoms are not associated with a DVT. So let me tell you why. Alright, so arteries and veins run down the medial side of your leg. Nothing runs down this side. Arteries are more lateral, veins are more medial, okay? So you're not going to hurt on the anterior part of your leg because of a blood clot. You're going to hurt on the medial and into the calf. So if they come in hurting on the front of their leg, it's not a blood clot. And they're going to say, oh, I'm hurting on the front of my leg. Why aren't you looking there? It's simple. Say, you don't have any arteries or veins on the front of your leg. Okay? I'm not looking there. So anterior leg symptoms are not associated with a DVT. So one big thing that's commonly seen with an acute DVT, not chronic, not subacute, is called phlegmasia correla-Doan. It's a big word, and there's a picture in the book somewhere that we'll get to hopefully. But these 3 things have to be going on to fall into this category. Alright, 3 things that must be going on. One of them is you have to have massive thigh or leg swelling, calf swelling. Just a little bit swollen, massively swollen. Another one is cyanotic limb. That means that your leg or your arm is blue. Okay? When I'm talking about DVT, I mostly say legs because it's more common in legs, but it can happen in your arms too. So your limb turns blue. And the last one is it's caused by iliofemoral thrombus. So the common femoral turns into what? The external iliac. So that means you have a thrombus in your iliofemoral region. If it's a thrombus anywhere else, it's not phlegmasia correla-Doan. Even though your limb may be blue, even though your leg may be swollen, it has to be a thrombus in that vein. Okay? So those 3 things, if you have all of that, you fall into that category. Got it? Alright, you can also have a blood clot in your superficial system. So what are the superficial veins? Greater saphenous vein and lesser saphenous vein. Will you get a blood thinner for those? Not unless what? It's near the D system. So common femoral vein or greater saphenous vein would have to be near the common femoral vein. Lesser saphenous vein would have to be near the pop vein, right? But we're up to the lesser saphenous vein. It's called the Giacometti vein, but where does it have to enter? Anywhere above the pop vein. So you just need to figure out where it goes into the D system at. Alright, so you can have a blood clot in these veins. It's called superficial thrombophlebitis. It's at the bottom of page 111. It's a big word. And symptoms of this are local arrhythmia, so local redness, okay, local tenderness and pain, and you can actually feel what's called a subcutaneous cord. So that means you can feel the thrombus inside the vein. Why? Because they're superficial, so they're right below the skin. So they have a thrombus in it, you can feel it. Alright? So superficial thrombus, it has a local redness, local pain, and a cord you can feel. And that's why, because it's so close to the skin. Okay. On the top of page 112, there are reasons to why you will do a venous scan and reasons to why you do an arterial scan, and they're in this little chart here. At the top of 112, it has a note, and it tells you the reasons because normally your insurance, Medicare, will not pay if you order an arterial and a venous on the same patient for the same reason. Okay? So there's reasons that we need to know. Now, is it going to matter? Not really to us, but it's something that we can have cash to just make ourselves a better employee. For instance, if they ordered a venous exam because the foot was cold, well, that would make sense. That should be an arterial exam, okay? Or if they ordered an arterial exam for a DVT, that'll make no sense, okay? So you just kind of have to know the differences. So just look at that chart. Let's see if there's any words that you might not understand. SOB means shortness of breath, okay? A lot of people don't get that one. But the rest of that, y'all should pretty much understand. This goes with venous, this goes with arterial. Shortness of breath and chest pain, that's the same with a pulmonary embolism. They got a clot in their lungs, they start having trouble breathing. Now, the next little bit of this goes through how to scan, and I'm just going to kind of run through it real quick because we're not scanning it yet. We talked about a little bit last week, and some of y'all got to see me scan, but you first want to start in transverse, and you're going to start in the groin here. And what anatomy do you see there? The common femoral artery, common femoral vein, and the greater saphenous vein. Now, if you scan up higher, if like you're here and you angle your probe up, you're going to get the external iliac vein. Because the external iliac vein, we know common femoral vein turns into that. So if you angle up, you'll get it. But most commonly, you put your probe right here, and you're going to get the common femoral artery, common femoral vein, and the greater saphenous vein, which I showed all y'all last week. All right? So you can turn on over. It goes over using color and using compression. The top of page 113, keep your transducer perpendicular to the vein. All right, so stay right on top of it when you push. You barely have to compress to make it close. Y'all seen that last week. A normal vein, like in this little diagram, when you compress it, it should close. But if it has a DVT in it, guess what? It's not going to close. So, whether it be acute, subacute, or chronic, when you push that vein, it's not going to close all the way. You want the wall to touch completely to rule out a DVT. Some of this stuff I just don't need here. You can turn on over to page 114. At the very top of 114, there's an image of just the common femoral artery and common femoral vein. So that is a picture you can also get, but most commonly, you'll just angle, bring your probe down slightly, and you'll bring in the greater saphenous vein, which I showed y'all. Now, a common variant is seen is the second image. Okay, the second image is the superficial femoral and the profunda. Okay, they're arteries and the common femoral vein. That's called the Mickey Mouse picture. But you can see in this picture the greater saphenous vein is coming in. You see that? So if the greater saphenous vein is either going to come in at the common femoral artery, common femoral vein picture, or it's going to come in as a second picture, which is known as the Mickey Mouse, which is the SFA, PFA, and the common femoral vein. So you can get the greater saphenous vein entering the common femoral vein in either of these pictures, picture 1 or picture 2. Okay? To get to picture 2, all you would do from the groin here, the common femoral artery and common femoral vein, is bring your probe down slightly and the artery splits. Just like vein has the SFA and the PS, or the SFB and the PFB, artery has the SFA and the PFA. Okay? Same thing. So if you're here, you can just bring your probe down slightly, the artery splits before the vein. Okay? So that's why you don't have an SFB and a PFB in this picture. Now, if I split down a little bit more, then I would show where the common femoral vein splits into the SFB and the PFB. So, just very little movements in the leg gives you a lot of different anatomy. So you start up here in the groin, common femoral artery, common femoral vein, greater saphenous vein, you may find it here, or you may slide down a little bit to where the common femoral artery splits, and the greater saphenous vein may enter in that picture. So either picture, we got it? Can come in now. All right. At the bottom of that page, 114, there it shows you a thrombus in the greater saphenous vein. See that? See how the greater saphenous vein has got the Y echoes in it? That's a thrombus. Now that is going to be a subacute thrombus. The reason is because the greater saphenous vein is still a normal size. You'll learn the normal sizes of it, but you can see it in there. So that falls into the subacute category. Now you see how the greater saphenous vein is about to enter the common femoral vein, right? So they're probably going to need a blood thinner there. That's where it's entering the deep system. So those are the ones that we do worry about. It says at the bottom of 114 that you want to compress every 2 to 4 centimeters as you go down the leg. So every time you move your probe, just go ahead and compress. A lot of techs get into the protocol, and so let's say you put the common femoral, then you get prox, mid, and distal. All right, they'll just pick their probe up instead of following the vein down and compressing. But they're just supposed to put the Because if you pick your probe up from here to here, what if there's a thrombus in here? You don't know because you didn't scan right there. So it's important to keep your probe all the way down the leg and just compress as you go down. Alright? You can turn on over to page 115. Now this is a drawing at the top, okay? But here we have the SFA and the PFA. So we already seen that picture on the black and white right here with the common femoral artery splits in the SFA and PFA. Now I said if you slide down a little bit longer, what will happen? The vein will split. So that's what this picture is showing you. So they slid down a little bit more. Now the vein has split into the SFV and the PFV, or the deep femoral vein, whichever one you want to call it. Okay, so that's what that's showing. They just slid down a little bit more, and so that you're getting all four of anatomy there. This picture here we don't ever get. Okay, take it wise. But should you check that level? Yes, but you don't take that picture. All right, if you slide on down the leg, the common femoral vein will split into what we know, or the common femoral artery, whichever way. It splits into the SFA and the PFA, right? Now the PFA is a really small branch that runs medially. Okay, so you're done with it. All it's used for is, I think I told y'all last week about the PFV, how it's just a collateral connection. The popliteal vein can connect to it. If like this area here is all occluded, the popliteal vein will connect to it to get blood flow back up to here and get it to the heart. Okay, so that's all. The popliteal artery and the popliteal, I mean not popliteal, but profunda artery and vein are only used as collateral. That's really their main purpose if there's an occlusion. But as you go on down, so the common femoral artery has come into the proximal SFA and the SFV, okay? Just like this picture here, SFA, SFV. And you'll just scan proximal level, mid-level, and distal level, all right? So just know what you know about veins. What do you think the distal SFA turns into? The popliteal artery. So I'm saying if you know veins, you'll know arteries. It's just going the opposite way. So just think about it. The common femoral artery turns into the what? What's the common femoral artery turn into?
CFP.
Deep and superficial artery. Yeah. Right? Because what forms the common femoral vein? The SFV and the profunda vein, right? All right. So then what does the common femoral artery turn into? The SFA and the profunda artery. It's the same difference, all right? So what does the proximal SFA turn into? Mid. What does the mid SFA turn into? Distal. What does the distal SFA turn into? Pop. What's the first branch off the pop? The anterior tibial. What's the second branch off the pop? The trunk. What does the trunk turn into? So it's the same difference. We're just going arteries now. Anyhow, y'all got it? Same difference. We're just doing arteries and veins go up. Okay? Pretty much sum that up. Okay. So turn on to page 116. We talked about this last week, about the normal Doppler method, spontaneity and respiratory spasticity. Showed y'all on Jessica how that works. Spontaneity means that as you put your probe down, flow happens. You don't have to augment. Y'all know what augmentation is now. We don't have to do anything. Flow just happens, right? And again, I'm at the bottom of page 116. Spontaneity. Respiratory spasticity means it's going to change as she breathes. She breathed in, flow stopped. She breathed out, it resumed again. Okay, or just your normal, just laying there. You can see how it went up and done like that. Okay, so that's respiratory spasticity. So you expect to see these two components inside of a normal vein. Turn over to page 117. The first little paragraph says spontaneous flow with respiratory spasticity should be seen in all deep veins superior to the calf. So what veins will respiratory spasticity and spontaneity not be seen in? What is inferior to the calf? What's inferior to the pop, the easier way to say it? Anterior tibial, posterior, and perineal. So those three veins, you are going to have to actually squeeze below the probe to show flow in them. okay? So the posterior tibial vein, the perineal vein, and the anterior tibial vein do not have the spontaneity and respiratory spasticity component. To show flow in them, whether it be color or spectral, you have to squeeze distal to your probe, just like I did on Jessica, and make flow come into those veins, okay? So again, the posterior tibial, perineal, and anterior tibial do not have spontaneous flow. You have to augment distal to the probe and make flow come up their leg, okay? Now sometimes it'll happen, you'll get a good patient that comes in, but if you don't, it's okay, that don't mean they have a blood clot there. But if I'm Doppling the common femoral vein, and it doesn't just flow, come in by its own, that's a problem. Or if it doesn't change with her breathing, that's a problem. But anything below the pop vein, that's okay. That would be a normal finding, all right? Now, there are some reasons to why respiratory spasticity may not be present, and it doesn't have to mean that they have a blood clot. If they're a shallow breather, okay, they don't breathe in deep and breathe out deep. They just kind of slowly breathe, and that respiratory spasticity component is not going to be that definable. Patients who are lying completely supine, you're not supposed to lie completely supine. Your head's supposed to be up a little bit, and your legs are supposed to be lower than your heart, and for this kind of study. If you have your arms raised up above your head, you lose that respiratory spasticity. Spinal cord injury. Why? Because their diaphragm doesn't come up and down correctly. So again, if the diaphragm doesn't move down, it doesn't increase that pressure in the abdomen, which doesn't close the IVC. So you got to have that normal movement of your diaphragm. And then a proximal DVT, obviously, could result in respiratory spasticity being known. Okay? There's one thing up in my head. Yes, if you lose the respiratory spasticity component of a vein, you need to look proximal on that patient. Okay? So if you lose the respiratory spasticity, look proximal for a DVT. And if you lose the spontaneity, look distal. So if you lose the respiratory spasticity of a vein, you need to look proximal for a DVT. But if you lose the spontaneity, then you need to look distal for a DVT. So if I'm Doppling my common femoral vein, and it has no respiratory spasticity component, what vein do I need to look at? If I'm Doppling my common femoral vein, and it doesn't have that respiratory spasticity, which vein do I need to look at? External iliac, which is proximal to my common femoral, right? All right, what if I'm Doppling my common femoral vein and it doesn't have spontaneous flow? What vein do I need to look at? Superficial femoral vein, because it's distal, right? This common femoral vein, what's distal to it? Superficial femoral vein. That's what you need to learn now. Those are very important facts that will help you when you start scanning. Okay? The bottom page 117 is a steady, continuous, non-phasic flow seen unilaterally in the common femoral vein means you need to scan the iliac veins, which is just what I said. So it's continuous, it's non-phasic, that means it doesn't have respiratory spasticity. So we need to look proximal, which would be the iliac vein. There's a reason it says unilateral, okay? If it's bilateral, then the patient has a decreased cardiac output. So if you find continuous flow in the common femoral vein on both sides, then that means that the patient just has a decreased cardiac output. So bilateral continuous flow in a common femoral vein means decreased cardiac output. Unilateral means you need to scan the iliac vein to look for a DVT. If you don't know the difference between continuous and respiratory spasticity, there's two pictures for you on 117. The top one is respiratory spasticity. It goes up, stops, goes again, stops. The bottom one is continuous. It never stops. You see, it just goes, and that's what's called continuous. It never changes with your breathing. Okay? So those are the difference. Again, bilateral common femoral vein continuous, heart problem. Unilateral continuous in the common femoral vein, scan proximal to see if there's a DVT in the iliac. Alright. So turn on to page 118. It goes over calf vein imaging. A lot of vascular labs don't even scan the calf vein. And these are some reasons why. Number one, because a thrombus in the calf vein are so small that even if they broke loose, they're not going to get lodged anywhere and cause a problem. Okay? That's one reason. Another reason is calf veins do take a lot of time to scan. And it says more often, techs don't have the experience, which y'all will learn the experience here, okay? So y'all will not be able to use number 3 as a reason, even though some people are trying to. It says calf veins should be imaged, particularly if the patient is symptomatic. So where do most thrombosis start? In what vein? In the soleus. Where are those at? In the calf. What do they drain into? The perineum and the posterior tibial. Correct. So if they're particularly hurting in their calf, we need to look at the soleus. And then we need to look at the posterior tibial and the perineum to see if there is any blood clot there. Alright, turn it on over to page 119. Some other reasons that a patient may be hurting in their calf is what's called a popliteal synovial cyst. You may have heard this word as a Baker's cyst. Everybody ever heard of a Baker's cyst? At the top of 119. The little star? So a popliteal synovial cyst is also called a Baker's cyst. On a test, I will word it as a Baker's cyst. Baker's cyst. And I have some pictures I can show you too in a minute. But a Baker's cyst is just like a cyst you get on your ovary or anywhere else. It's just behind your knee. So the fluid-filled cyst behind your knee. Okay? It's not in an artery. It's not in a vein. It's just a pocket of fluid builds up behind your knee, and it's called a Baker's cyst. And what it can do is it can compress on your artery and vein and cause blood to just kind of go back down. If it's compressing the artery, that's causing ischemia because now it's limiting the amount of blood flow that can even get to your calf. So those are 2 reasons why it could cause pain. A hematoma is a bleed. Okay, so an intramuscular hematoma, if you're bleeding on the inside of your muscles, that's obviously going to be a little painful. Lymphedema is excessive fluid. Your body is supposed to drain your lymphatic fluid into your lymphatic system. Sometimes your lymphatic system's not working correctly, so all that lymph fluid just kind of backs back up, like a form of reflux. So your body starts swelling because of the fluid. It's called lymphedema. And then an abscess is also. So those are all reasons to why you also could be hurting in your calf. Okay? We use this book in the rate too, so there's some of the stuff I've got highlighted that I don't need to tell you while I'm reading it. Calf anatomy, posterior tibial vein are paired. Remember, posterior tibial, perineal, and anterior tibial have 2 veins. So they're paired veins, and they lie with the posterior tibial artery. And they're posterior to the tibia, which is where they get their name, posterior tibial. Okay? Perineal veins are also paired veins that lie with the perineal artery, and they are medial to your fibula. So they're, like I said earlier, you're going to find them in the calf as you start scanning them. Anterior tibials are also paired veins that lie with the anterior tibial artery, and they're lateral to the tibia. So that's where you put your probe right here to this bone, lateral side, and you'll get the anterior tibia, okay? And then the tibial-perineal trunk is formed by the posterior tibial and the perineal vein, and it will join with the anterior tibial vein to form the popliteal vein, which you already know that, okay? So when you scan in the popliteal vein, when you scan down the leg, you're going to see a branch into 2 things. The one that goes lateral is the anterior tibial, and the one that continues medial is the trunk. And then you'll see the trunk split again as it splits into the posterior tibial and the perineal. But again, we're scanning like 6 quarters, okay? So, all right, soleal vein veins, we just talked about what those are. They drain the scapular muscle, and they go into the posterior tibial and the perineum. Gastrocs drain the gastroc muscle, they drain to the pop. And gastrocs do have arteries with them. So what you'll see is like the popliteal artery and vein, and then you'll see like all these little dots above it, almost at the top of your screen. Those are gastrocs. Okay. Goes into the superficial system. Another word for lesser saphenous, I said a small saphenous. And of course, we know that it's supposed to drain into the popliteal vein. If it doesn't, it's called the Giacometti vein. Greater saphenous vein should drain into the common femoral vein, longest vein in your body. I'm just telling you some facts about it that you should know. And then perforating veins connect the superficial system to the deep system, and that's how blood should drain, superficial to deep. All right? I think we need to go with any of these scanning techniques. First of all, the patient should be in reverse Trendelenburg. Y'all know what that is? It's where your legs are lower than your heart. So your head's up here and your legs are down here. And why do you want your patient in that position? What does that do? Makes the blood pull down and dilate your veins. That's what you want that to do. Okay? If you look underneath that first picture, they are medial to the ankle bone, so they're getting the posterior tibial vein right there. So when you start scanning those, you just go right behind the ankle bone, and that's where you get posterior tibial, okay? The very last image, you get posterior tibial there too. I don't really like them right there, but where he's got his probe at is a common place to get perineals. So you can get perineals in the medial calf area. Again, what do you have to do to show color and Doppler in the posterior tibial, perineal, and anterior tibial? You have to augment. Why? Because they don't have what? Spontaneity. Good. Very good. Don't worry about nothing on that page. Go to page 122. This is like the longest chapter in the world. I know. On calf imaging, it says color Doppler and longitudinal works better than color and transfer when you're looking at calf. And I'll teach you to lengthen your veins out and show color and long, just like you do your carotids. Extensive swelling in the calf is not related to thrombus in the tibial, so it's meaning that it's not because of the anterior tibial or posterior tibial perineal. The popliteal veins or more proximal veins have to be the cause of it. Okay? So extensive swelling in the calf is not going to be related to a thrombus in any of those calf veins. It has to be because there's a thrombus more proximal, anywhere from the pop up. Okay? We'll cause it extensive swelling. Flow in the calf veins is usually not going to be spontaneous, which we talked about. You have to augment flow by squeezing. Also, I guess I'll tell you this, but if you'll have your patient just do their foot like that, it's augment. I don't like to tell y'all that because y'all will not augment, and you'll let your patient do that as you're scanning them, and then you won't learn how to do it correctly. But if you want to do it that way and cheat yourself, you can. All right. If a patient is symptomatic in the muscles, we need to be looking at what? What vein? In the calf muscle. If a patient is symptomatic in their muscular veins, which is their calf muscles, we said soleal. Okay? Why? Because that's where most DVTs start. Okay? And then it says if you find thrombus in the lesser saphenous or the short saphenous or the gastroc, you need to definitely scan the popliteal vein to see if it extends into that. Okay, don't worry about that. I'm going to page 123. Does anyone need 5 minutes? Yeah. 5 minutes? Okay, we'll start back at 5 minutes. I really just want to stretch.
Ever since you talked about something.
We got time. I want to get my drink.
I highlighted some of those issues.
there's, tornado watching. Southwest.
Not this year.
Not around here.
Yeah, it's coming up this way though.
Oh, really?
But they're saying they're not expecting tornadoes here. So they're just gonna keep
I think we've
updating.
already hit the high for today. Am I
I think so. I think you're right.
Is this spring?
Sorry.
Oh, is that your reading it?
That big video just was female. That quiz had me. Oh Lord, my window rolled up. Cause I rolled it up and not rolled it down this morning.
I'm sorry. That's all. I thought about that thunder bite.
Thunder buddy. Oh, when they thought he was like.
My sister sang that song all the time, and I'm like, Kelsey, please shut up. She's like, you don't want to be my thunder buddy? No, go in there. Go on there or something.
I got this like that girl and she, like her whole leg is like bluish, purplish, and like the skin peeling. And I'm scared to ask her like what's wrong because I think they're appropriate. But I was always wondering like what is it? Could that be?
Like purpley or brown or?
It's like purplish red, looking dead. Look.
She could have like extreme cases, cellulitis, which we're gonna talk about in a minute, or she could have reflux that's really bad, because the blood just sits there, it's starting to eat away at your skin, it's gonna change the color of it, the texture of it. Does it look like she has a pair of socks on? You ever seen someone else they have socks on and they don't?
Yeah, that's what it looked like, but it's not brown. It's
Not
like
brown, yeah.
reddish, bluish.
Yeah.
And she walked with a limp, like you can tell it hurt because she walked with a
Yeah.
limp. But she comes her every week, huh? She's sweet, but I'm scared to just ask her.
What is the cause of, what is caused by obstruction of the lymph?
I'm gonna do those. I was looking at Kimberly. It's a, what's Simedics? Virtual Online Simulation Program?
Oh, it's on the computers, and what it is you probe, or your mouse is actually like a probe, and it helps you know, like, if you put your probe here, what an avenue you see.
Oh.
It's really pretty cool. And there's more stuff you can do with it too. What's your baby name, Molly? It's a boy, right? Ring
Ms. Abels, did you say again, and it's on here, but unilateral continuous flow, iliac vein may be due to the other decreased cardiac output?
Thrombus. Unilateral is a thrombus.
Okay. Thank you.
In the iliac vein, yes. And the bilateral is heart.
Is decreased, okay.
Yep, iliac vein thrombus. Okay. You got it.
Whenever we're, getting places like, at our places somewhere like, that we're better at like, worms is better,
There's certain sites that we have to send certain students to, because they ain't gonna take anybody but the best of the best. We send someone there that's average, they'll clear us out, but what you like the certain sites, there's certain sites that we have to send the top students to.
Criminal
Top of the
crime.
top, I'm not gonna tell you those sites, because then you'll know who the top students are. I'm not gonna tell you those sites, but anyhow, but no, you have to go and you have to get a variation of everything. So let's say we send you to a vein clinic next quarter. Well, in the next quarter, you need to go somewhere that does general, and in the next OB, we gotta give you like a variation.
But I'm not gonna do it, like.
You still have to do comps on it. You have to do transvaginal, breast, OB comps, you have to do it all, just like a girl would, just like we have to scan scrotum.
How many can go to this site, like two to each side, or do they one to each side?
It depends on the size.
Oh.
We have some sites that'll take it to 4. So
Oh, okay.
it just depends, but then we have some that can only do 1.
Right.
But all of them, if it's going to, if we go to one that's 4, we're all 4 supposed to be at one time?
Let's see, y'all are Tuesday, Thursday next quarter. So y'all can go on Monday or Wednesday.
Oh, okay.
We have one almost up in Tennessee. Well, no, we do have one in Tennessee now. We have some in Georgia, Mississippi. We have them just spread out.
Wow.
If you live, like north of Birmingham, you get to go to the Huntsville side, which is the Tennessee side, and the Florence side. I mean, you can still go. You can still go, but, yeah. Oh, I know where Chelsea's at.
Around 280, right
Yeah, I think it's down 280.
Children's, what's around it? Childersburg?
I think.
Yeah.
So your closest site's Alabaster or Sylacauga.
Yeah.
So you would be the ones that, you would be going Jacksonville, Anniston, Sylacauga, Talladega.
That's probably Pell City too.
Yeah.
Do you have,
Montgomery sites too, no?
do you have to
They have their own school down there.
St. Vincent, St. Clair, in Pell City, we go there.
I'm fine.
That's what.
Yeah, the ultimate school,
What's the name of it?
Yeah, they have an actual school in the hospital there, but they only take like 3 or 5 students. You live somewhere? Where you live? Girl. Now I know.
The new hospital right now.
Well-
Open up right as soon as we start closing.
It's not supposed to open next first of the year, is it?
It's supposed to be opening up.
Is it in 2016? Cool. Nope.
And I know for a fact that we not have anybody hired from, so.
That's an interesting fact. Okay, thanks for telling me.
What about that new one on 280? That wasn't like.
Oh, that's one of our sides. That's one of ours. Yep.
I'm gonna ask my dad about it, how long because his company is the one that's working on hospital Brasco Court. So I'm gonna ask him how long. Cause that's Thursday.
Okay.
They ain't made much progress.
That's what I'm saying. I can't believe there's somebody else in that place. All right, so let's start back on page 123. And we're going to go over, again, the different types of DVTs and how you know if the patient has one or not. So at the top of 123, it goes over criteria for patency. Patency means the vein is compressed as normal, no blood clot in it. So one way that you know the patient does not have a blood clot is the first thing that should be on here is it fills up with color. Okay? And it is. It's on here. The very last one, blood flows throughout the lemon with color Doppler. But let's make that number 1 on the list. All right, the second one, which would be the first bullet, is the vein completely compresses. The walls touch completely. Okay? The second, there's no thrombus inside of it, but again, what type of thrombus can you not see? Acute, so you can always rule on that one. And then your normal venous Doppler signals, spontaneity and respiratory fascicity, right? Anything above the pop vein enough. So what happens if you lose your respiratory fascicity? Where do you need to look? Proximal, spontaneity, distal. Good, all right? So those are all the normal things that should be going on. Now, if they do have thrombus, it says criteria for venous thrombosis. 1, you consider thrombus inside of it. It can be completely or partially obstructed. Look before you compress. Key word, look before you compress. All right? So if you see thrombus in it, it doesn't fill up with color all the way, it doesn't compress all the way, well, those are things that should let you know there's a thrombus inside there, okay? This showing an uncompressed and a compressed picture. Now look at the uncompressed picture. That vein, a pop vein, looks anechoic. It looks a good size. So before I even compress that baby, I'd have put color on it. But anyhow, then it shows the compressed side. You can see how the vein didn't close at all. So that patient has an acute DVT because the vein is normal size. It's anechoic. All right, so that's what an acute DVT would look like. Now, and it says distension of the vein compared to the artery. Again, that falls in subacute and acute cases. Okay, that the vein is still bigger than the artery. Looking at the bottom picture on the right of your page, what kind of thrombus is that? Is that acute, subacute, or chronic? Wrong. No. Subacute. What makes it subacute? So the second image on the right side, the transverse image. Well, yeah, we're just bouncing around the fact. Normal size vein makes it sub, okay? But what makes it subacute? You can see the thrombus inside of it, all right? So that's subacute. The vein is still bigger than the artery, right? But because we can see thrombus in it, it has to be what? Subacute. If that vein was smaller than the artery, what would that be? That'd be chronic. Good. So it's very important to look at your vein size, okay? So that is a subacute thrombus. All right, so again, abnormal venous Doppler signals is the bottom two. These are things that make you wonder if the patient has a DVT. So they've lost their spontaneous or respiratory fascicity. This goes over continuous flow in the common femoral vein, which we have done talked about. I'm not going to discuss that again. At the first bullet on page 124, free-floating, partially attached thrombus should not be aggressively compressed. Okay? Why? It's because it can break loose. And what type of thrombus is free-floating? Acute and subacute. Very good. Patients with acute DVT should be transported to the physician's office. They should not walk after you find an acute or subacute. Can they walk with a chronic? Yes, why? Because it's attached, very good. And then you should let your physician know promptly of the results if the patient has an acute or a subacute DVT, okay? And then it goes into chronic DVT. Chronic DVT should last longer than how many weeks? Present longer than 12 weeks. Chronic DVT implies that thrombus has been here for at least several months. 12 weeks is what? 3 months? Okay? Thrombus has increased echogenicity, which we talked about, right? The vein is contracted, often the same size or smaller than the artery. We mentioned that. In a very old DVT, the vein may be so contracted that you can't even see it on ultrasound. So that can happen. Now on the top of page 125, the first two bullets, we talked about recanalization, right? And recanalization appears to occur within the thrombus. It works like a worm digging a tunnel. Vein walls may be thickened due with the chronic DVT. Okay, at the last bullet underneath those pictures, the word globalis, I don't know how to say that word. That is when you have small, you have to write this in because I have it written in. That means that you have small, local, rounded calcifications in the vein. Small, local, rounded calcifications in the vein. That's what that globalis word means. And it is seen with chronic DVT. So small, local, rounded calcifications in a vein. Okay? And what's the one thing I didn't mention about chronic DVT? So what else can it form? It's not recanalization. What's it called? Collateral. So not forget that one. Okay? And then subacute at the bottom. Again, this is from 4 to 12 weeks. And it says that there for you. The difference, I hate these words. The difference between acute and subacute is often difficult, but one key word, especially when it gets closer to the 12-week mark, the thrombus starts becoming more echogenic, you can see. Okay? Alright, on page 126, in the middle, or not really the middle, the second paragraph, it mentions the word D-dimer. Anyone ever heard of a D-dimer? It's a blood test that they will do to see if you have a blood clot. If the D-dimer comes back positive, chances are you have a blood clot. But it doesn't always mean you do, okay? So if you come into the hospital, doctors always think you have a blood clot, they're going to do a D-dimer on you. If it comes back positive, you're going to get that ultrasound and see if you do. But if it can still be a false positive, just like a pregnancy test can be, okay? Alright, under practical stuff, acute thrombus located anywhere from the popliteal vein to the iliac vein is life-threatening. Again, because it can throw. Calf vein DVT may cause a pulmonary embolism, but the thrombus is too small to be fatal, like I mentioned earlier. That's why a lot of techs don't even scan the calf, because the thrombus is so little, who cares if it gets in the lungs? It's too little to cause any damage. Alright? And, let's see, the number 3, extrinsic compression of the iliac vein versus isolated iliac DVT. So if there is no DVT detected, but flow is continuous in the external iliac or the common femoral vein, you need to compare it with the other leg, right? Because what happens if it's bilateral continuous flow? It's hard, right? So you need to go ahead and compare it. And then it says, we'll look at these. In the images below, the left common femoral vein is continuous while the right is normal. The abnormal flow pattern was caused by compression of the iliac vein by mass. Okay? So you don't always have to have a thrombus to have unilateral continuous flow. It could be a pelvic mass compressing it. You'll see this a lot in pregnant women. Well, they will compress the iliac and look at continuous flow. Okay? So keep that in mind. It doesn't always have to be a DVT. So on the top of 127, this is the picture that says the left side is the continuous, the right side is respiratory spasticity. Okay? So this has nothing to do with their heart because it's just one side. So if it's just one side, we're thinking of what? A DVT in the iliac. or it could be a pelvic mass, right? And that's what it says. Unilateral continuous flow may be due to an isolated iliac DVT or a mass. And then bilateral continuous flow could be because, again, they breathe very shallow, they're supine, or an IVC obstruction, or heart problems, decreased cardiac output. So add that one in. And just one more time, if you lose your respiratory plasticity and your flow becomes continuous, look where on that patient? If you lose respiratory plasticity and your flow becomes continuous, you need to look where? Proximal. If you lose spontaneity, distal. So go home and learn your veins, because on your test, you're going to have a question like, while scanning the mid-superficial femoral vein, I noted a loss of respiratory plasticity. Which vein, something like that, do I need to look at? And then it's going to have a list of veins, and you need to pick the right one. Okay? So go home and know your veins, know what's proximal and distal to certain veins, and know which way to look. Alright, and let's see. Now, the differential diagnosis of calf pain and swelling. If it's not a DVT, what else could it be? We've done mention of Baker's cyst. Remember, that's fluid that builds up behind the knee. So on page 128, it's got, at the top of the page, it's got two types of Baker's cyst. The first one is a brand new Baker's cyst, okay? The second one is a hemorrhagic Baker's cyst. So which one of those do you think you want to find? Do you want to find a brand new fresh one, or do you want to find a hemorrhagic one, which means that your body is taking care of it? You want to find the hemorrhagic. If you find a hemorrhagic Baker's cyst, that means that your body is absorbing it and taking care of it on its own. If you find a Baker's cyst that's brand new, or that looks brand new, you'll have the patient come in. We hire come in like every 2 weeks to see if it started turning into cyst. If it didn't, they would have the fluid drained off their knee. Okay? Because you have to get it removed. So either you want your body to do it and become a hemorrhagic Baker's cyst, or they're gonna have the fluid drained off of their knee. If you do want the hemorrhagic, it's the better one to have. Now, popliteal cyst or Baker's cyst, they are going to be, again, behind the knee in the popliteal space. They can get so big that they can spread on into the calf, though. So if you don't get it taken care of and you don't get it drained, it's just going to keep building up, right? If your body doesn't do anything about it. So it can extend on behind the calf. They can rupture in the calf. Fluid can rupture, just like a cyst on an ovary can rupture. This can also rupture. We want them to become hemorrhagic, and they should not be mistaken for a popliteal artery aneurysm. An aneurysm is dilation of an artery, okay? But what is, one thing about a Baker's cyst, it's not connected to an artery or a vein. It's just fluid that builds up behind your knee. So you need to differentiate the artery and the vein from the Baker's cyst to prove to your doctor this is not just some huge aneurysm behind the knee. This is simply a Baker's cyst, okay? So show the difference between artery and vein, show that picture, and then show Baker's cyst. So then he'll know that you know. Okay? Hematoma is next. Hematomas are often related to injury, and they are a bleed that occur in the it says calf muscles. You can get hematoma anywhere on your body. It's a bleed inside the muscle. And let's see, page 129. Hematomas are not found behind the knee. Okay, so you're not going to find a hematoma behind the knee. If you find something behind the knee, what is it? A Baker's cyst. Very good. Alright. If you don't know what a hematoma looks like on the outside of a body, everyone's seen one with a hematoma, right? This looks like a bad bruise. You get hit really hard, or you've been a wreck or something like that. You cause a tear in your muscles, which causes a bleed inside the muscles, which results in a hematoma. Okay? So I figure we'd all seen a hematoma before. That's just a big knife from there. I'll see later. Okay. Oh no, this one's a pretty good one if you don't like bones. Got a bone on my kneecap. I don't really like those, so. I'm gonna pass out. And then again, there's another one, so everyone knows what a hematoma is. Alright, and it's a tear in the muscle, so it's usually caused by blunt trauma, something that hits you pretty hard, tore your muscle, now you're bleeding inside. Okay. Let's see, lymphedema is next, and we talked about this a minute ago, how your lymphatic system is supposed to drain all your lymph fluid. Sometimes your lymphatic system doesn't drain properly, which results in the fluid building up. It's a form of reflux, and the fluid builds up. What happens? You start to swell. Okay? So lymphedema, it says, is a very common cause of lower leg and ankle swelling. It's caused by obstruction in the lymph channels, resulting in an excess of lymph fluid in the tissue, usually in the foot, ankle, or leg. Lymphedema, that was country. Okay. Lymphedema, yeah. Ultrasound-wise, it looks like these pictures. You see these pictures? It's called the ant farm appearance. Looks like an ant farm. Okay? Now, pitting edema, everybody know what edema is, right? It's swelling. You can have non-pitting and pitting. The difference is, if you can push down on someone and leave an indentation in their skin, that's pitting edema. That means they're very swollen. Now, if you push down and it leaves an indentation, but it comes back pretty quickly, that's non-pitting edema. Because anybody that has swelling, you're going to be able to push in on their skin. But if the indentation stays there for a period of time, it's called pitting edema. They're so swollen, that's like pushing in on a marshmallow or something. You know, it just kind of stays in there. So it has an ant farm appearance. And it says swelling is reduced in the morning and more severe later in the day. Why do you think it's worse later in the day than it is in the morning? What are we doing more during the day? We're moving around, we're walking, standing, so we're causing the fluid to just go down to our legs and swell. Alright, so some pictures of lymphedema. I'll turn this off in just a second. Just to show you some different variations. Some of these are more extreme than others.
Oh, yeah.
So she has a very severe case of lymphedema. Anybody ever heard of elephantitis?
Right.
That's horrible lymphedema. That's what that is. Okay. So what'll happen, you start weeping. You ever heard of weeping? Where the fluid drains out of your pores. Like seeps out. That's called weeping. That's what it looks like on ultrasound. Ant farm appearance. What is all this black stuff here? What do you think that is? Fluid. Exactly. Very good. There's another case. Again, this could be like elephantitis or whatever going on too, because they are pretty swollen there. Ooh, I love this one. Look at that. She ain't got no ankles. Got legs. I know. That is horrible. Can you imagine carrying that around?
It just starts.
It's more commonly seen in overweight people, but it can happen in your normal size individual also. But the lymphatic system just stops working correctly, like anything else in your body can stop working, and it's the fluid starts backing up. And eventually it can only back up to a certain part, and then it's going to start coming out your skin, and that's called weeping.
Don't a lot of diabetic people get that swelling?
Mm-hmm.
I remember my grandma.
Yep. You can actually get, you can get put on some medication, you can get the fluid drained, but if your lymphatic system not working correctly, it's going to be a chronic problem. You can go and get drained every however often, but yeah, it's going to be a chronic problem that you're faced with. This is a good one here. Lymphedema of the scrotum sac.
Oh, my goodness.
Oh, Lord. That cracks me And then more. There's that one. See how the other leg's skinny? You can tell that now it's just swelled up. And then you go again, you get it in your hand too. So lymphatic drainage. You're going to lose your whole body there. So this is an Asian guy back here. Oh Lord. lymph nodes. You have lymph nodes all throughout your body. Sometimes you see lymph nodes. What's the most common reason for finding lymph nodes? Infection. You're sick. So you're going to see lymph nodes on almost everybody in the hospital that you do karate on because they're sick. That's why they're there. You can see a lymph node, but it says they're commonly seen as growing, and they're kidney shaped, and they can be swollen with infection or cancer. So if you find lymph nodes, it's very important that you Doppler how many you find, and you put color on them. Okay, lymph nodes should have a little bit of vascularity, but if they light up like a Christmas tree, that's called lymphedema. I mean lymphoma. We've all heard someone probably have lymphoma. That's cancer, okay? So if you find a lymph node, measure it, put color on it, and measure every one that you find.
Will they only show up if they are infected?
Lymph nodes should really only be seen if you have an infection. It could be a simple cold to make your lymph nodes increase in size. Yep. And it says they should be measured and they cannot stretch out. So a muscle can look like this picture here, but if you turn on a muscle, it lengthens across the screen. Lymph nodes do not. So if you're measuring, or if you find a lymph node and it looks something like this right here, that's a problem. That's probably lymphoma. Okay? And it can start out with one, and then it's just going to increase as the cancer gets worse. So anytime you find one, measure it, color on it, and see if there's any more around that area. All right? Turn it on over to page 130, which is cellulitis. Hurry up, thank God we're almost done. Alright, cellulitis is an infection that gets into your soft tissue, soft or connective tissue. Just like an infection that gets in your body, except for this one gets into your skin or tissue, okay? The limb becomes red and streaky, and it's warm, and it becomes shiny. Very painful. Most people say cellulitis can't even stand a sock or a sheet touch them. So imagine having to scan someone for cellulitis. It's horrible. Yeah, it is. It's not related to DVT, but for some reason, doctors are going to order it like crazy. And you're like, this patient does not have a DVT. They have cellulitis. But anyway, you have to go ahead and scan them and squeeze their leg and do all this sort of, put them through, for a little while. But anyway, so the limb becomes very shiny and warm and streaky and red. And so this is cellulitis. It's like when they got burned. But you can imagine how painful that is. Very painful. And it's commonly seen with diabetics. And you can kind of take a look at her feet, and she's a diabetic. So cellulitis, that's what that looks like. And then the ultrasound of cellulitis, it looks a lot like lymphedema, to be honest. It's like a it looks a whole lot like lymphedema. Really, the only difference is lymphedema has more fluid in there. But since it's infection, it shows up as fluid. Okay? So cellulitis and lymphedema have sort of the same appearance on the inside, but on the outside, completely different appearances. Alright, and then compression syndrome is next. The IVC lies to the right side of the aorta, which we all know that. The left common iliac vein courses underneath the right common iliac artery. Okay, so the common iliac vein of the left side courses underneath the right common iliac artery. In certain patients, especially women that are pregnant, what will happen is they will compress the left common iliac vein, which results in iliac thrombus. Because if you compress your iliac, what happens? All the blood backs up. So it can cause thrombus in their iliac vein. And this is called May-Thurner syndrome. So when the common iliac vein becomes compressed, it's called May-Thurner syndrome. Alright? So all you really need to know about that. And then other things that you might find while scanning the legs are tumors, abscesses. Abscesses are seen with infection, so increased white blood count they should have going on. They're going to actually have swirling debris within them. That's the infection. AV fistulas can be seen. Arteries and veins should not be directly connected. Capillaries are supposed to be between arteries and veins. That's how blood gets from one side to the next. Sometimes they connect to each other, and that's called an AV fistula. And we're going to learn a lot more about that later. but just know that when an artery and vein connect to each other, it's an AV fistula. Okay? And then pitfalls, a heavy hand. When you're scanning legs, like Jessica can tell, I'm barely touching her. Okay? If you press, you're going to come close to compress the vein if you put too much pressure. So it's very important, just like you do with your carotid, to barely touch them. Any vein segment that does not compress should be carefully evaluated with color, and look at it in sagittal also. See if there's a thrombus in there. Be aware of a bifid system. Jessica has a bifid system behind her knee. And we had, if I was scanning her, I'd have to look at all her veins, not just the one set. We learned about those. It's on page 131. About that, we're not talking about that. The good thing about venous imaging is the second diamond, you don't have to have an angle correct. It's awesome. Remember, you're at 0 degrees, so good to go. What I don't agree with is the second one. Normal venous flow can be seen above or below the baseline. No. What did you learn in chapter 1? Veins go below the baseline. So I don't agree with that. So if you read it and mark it out, I don't like that. And then the last little one, in the event you're required to perform a venous and an arterial exam on the same patient, perform the venous exam first to rule out DVT. Okay? Because normally when you do an arterial exam, you do blood pressure cuffs like you've been seeing the seniors do. So what would happen if a patient had an acute DVT and put those cuffs on? Wouldn't be a good idea. So do the venous part first if you are required to do both. And then the last thing is venous insufficiency, which we have went over and went over and went over. So y'all all got to send me augment. Remember, I was augmenting to make sure what opened? The proximal valve, so the blood can go up the leg. So you augment for reflux, and what else do you augment for? A DVT. Remember, if there's a DVT there, it can block the blood flow. What do you do the Valsalva maneuver for? Making sure the proximal valves do what? They close. So when you bear down, you don't want flow to go back down your legs, right? So remember what Valsalva is. Remember what augmentation is. But that one, I think you just hand in to. So let me look. Y'all next test is your final. You don't have the next test. Your next test is your final. You go. The presentations are just due to me on December 9th. You just hand them to me, and it's 100. So if you turn in test grade, it's 100. Presentations have to be 12 fonts, 2 pages of written stuff, then turn in some pictures to go with your story.
We'll have to put references.
I don't need no references. Any vascular thing you want. Okay? It's due December the 9th. So, yeah. We're out next week.
Which one?
Not all week, like the elementary school part.
I think most of it is from down there.
Just scan. Yep. No homework due for 2 weeks. We're not here next week. Nope. Keep everything till the next week. For your final? Yeah.
I'm talking about both the bilateral.
Oh!
Yeah. So I'm going to class in 2 weeks, bring the other book.
Oh, yeah, that other one. Oh, the test, okay.
I'll look at it and see. You know which one it was?
I did.
What else did you missing? Let's see what you bring today. What you bring to eat today?
Same old.
Same.
Love my peanut butter and jelly. Well, I do, and it's just cheap. It's easy to keep.
You ever had a fried peanut butter and jelly?
No.
That sounds
I don't always do it, this one I did.
Anything fried sounds good.
I feel like I did, actually.
That's gonna go.
My stepdad used to eat peanut butter and mayonnaise.